So that's something you want to know, that little kids, they can tolerate things till they can't. Then after they hit puberty, right, and they have a bigger body and their organs are relatively in relation, they can tolerate things better. But also on the same side, the older you get, let's be honest, man, I'm over 40. Like that's it. The highlight of your life is done, bro. It's just all downhill. It's just a slow grind down. Doesn't mean you can't have good moments. Like I tweaked my ribs the other day playing wiffle ball. Okay, playing wiffle ball. I swung, I hit the ball, I ran to first, and then I literally keeled over. Like I think I pulled a muscle. Okay, it's sad because I went to that competition and crushed the competition. Literally, I crushed a weightlifting competition. I got hurt on a wiffle ball. Okay.
Right. I tend to blow out my knees walking around the classroom. So.
Yeah. It's not good.
You have to wait till next year. You're in Schedule 1.
I know, I'm done. 3 years in a row, I'm good.
Now, I hate to say that, I would knock on wood.
Yeah, knock on something, please.
Bird that had like a knee reconstruction at the same time I had a knee reconstruction, right? And one of us got the short end of the
It wasn't you.
Like, another knee surgery. She's like, yeah, the other knee this time. And I'm like, look at the other knee. She's like, and they're gonna get the other knee too. And I'm like, how many knees do you have? Because all of them are bad. I'm like, all right. Nervous system emergencies. Okay, this is what you guys really want to get to. Let's be honest. First part, little background. All right. I can't say this enough, right? A lot of the times, we'll have a situation where it's very overwhelming. Okay? And when you have an overwhelming situation, you're like, oh shit, a lot of blood, they're not breathing well. Stop. A, B, C's. Airway, open and bleeding. Are they breathing evenly and enough for adequate life? Something like boom, 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 boom. Okay? Do they have good circulation? Okay? Is there a mass bleed that you need to stop? Okay? Once we do this, you're going to be able to deal with these neurological issues. Because it's all about getting oxygen, glucose, right? And metabolite change to the brain and the rest of the body. Okay? So once you're able to handle that, say, okay, let's make sure that we got good ventilation. We have good breathing. So, in an event where we have a stroke or a neurological, what's one of the first things I want to do? I want to make sure they can breathe on their own. If they can't breathe on their own, then I'm going to have to breathe for them, right? I like an NPA. This is just me, right? Because they might have half of their face, might not have the nerve for the gag reflex, but the other half does. Let me put an NPA and we'll back. We'll get there, okay? Okay. Altered mental status. This is where you're going to start asking questions, right? If you're in a nursing home, you have to understand their baseline. So you need to have staff who deal with them normally. Because if they're altered normally, I don't want to sit there and call for a code stroke if they've already had strokes. But I want to make sure, is anything different? When did this happen? When did this start, right? What do we have? Your A&O times 4. Do they know where they are, who they are, what place they're at, time and date, okay? Here's one thing you don't want to ask. Don't ask who the president is. Okay? Here's why. Do I want to agitate a patient? Okay? No. No. Right? Like I don't want to fight with an 80-year-old about my political views when I just who's the president? And they're like, mother, I'm like, all right, here we go. Here we go. So what I normally ask, right? I sit down and go, what month is it? What year is it? I don't want to aggravate anything, okay? Like, I don't want to lecture the person that I'm giving Narcan to, why do you live this life? Okay, there's help. I don't. That's another conversation. That's for somebody that they got that bandwidth. I don't have that bandwidth, okay? So acidosis, alcohol, right? Okay, so acidosis, meaning they're not breathing well. A lot of respiratory infections, a lot of dialysis. You'll see that they're acidotic, okay? That's the big one. Another big one is what? Ketoacidosis. You can have it from diabetes, right? Untreated. You can also have it induced by exercise, where someone's on a keto diet and then they're exercising so hard they're using up all the glucose and they get acidic from all the lactic acid. You tend to get rhabdomyolysis, but you can get altered mental status on it. You see somebody doing a marathon and all of a sudden they're altered, right? We're going to look for electrolytes, we're going to look for acidosis, we're going to look for low blood sugar, we're going to look for all the things, okay? All right. Epilepsy. Anyone see this? What is epilepsy? Excessive electrical activity. Too little, brain dead. Too much, seizures uncontrolled. And so you have to make sure that you look at a patient, right? One is blood glucose. That's always the one that throws everything because it affects everything. It goes to every cell. So that's one of the first ones you want to make sure. Okay? Infection, sepsis, right? Temperature goes too hot, you get altered. All right? Brain's just on fire. And we know that enzymes get degraded when they're too hot, such as proteins, right? You take an egg, you got yolk, and you got the albumin. As soon as albumin reaches a certain degree, it denaturizes its usable form into what we eat as eggs. But in the brain, albumin, other proteins, they get deformed when it's too hot. That's why kids have febrile seizures when their temperature spikes too fast, right? Because that electrical activity is just wham! And so that's what you have to control. So, infection is a big one. Overdose in O2, okay? So overdose doesn't have to be opiates. It can be overdose of any medication, right? Because we can have, what? Too much aspirin destroys the kidneys. Our kidneys isn't making enough electrolytes. They have to go on dialysis. Big thing with ibuprofen use in a lot of professional athletes. Or excessive corticosteroid use, okay? O2. Anybody roll up to the trailer park? The lady smoking while on O2 with like 80 feet of hosing. And she's like, I can't breathe. She's got a cat. Can't get rid of Puffy. I'm allergic though. Like, what? Like get a stuffed cat. That cat is half dead. It's smoking a Marlboro with you. Okay, like it's just bad, right? Or around here, because the heating bills got so increased, what you'll see is, and I've had this happen, you'll see a lot of migrant farmers be there, and they'll have a kerosene heater that's supposed to be used for outdoors. They're using it indoors. They're getting carbon monoxide poisoning. So just last week, my wife's sister, right, my sister-in-law, they're twins, right, called me up because she thought she was having a stroke, okay? And she called me up from the road. And she was on the Long Island Expressway. She goes, I think I'm having a stroke. Who do I call? I can't see too well. I go, stop. You're talking to me, and roll down the window, shut off your car. Okay? She had a leak in her car. She was getting carbon monoxide poisoning. Okay? And so they checked it out. But she literally thought she was having a stroke because she couldn't put everything. And so I said, roll down the window, shut off the car. And she was fine 5 minutes later. She goes, what should I do? I go, get it towed. Not worth it. So there are things where that carbon monoxide, carbon dioxide poisoning gets to you. Okay, uremia, kidney failure.
Not yet.
Oh no, man, I'm not saying not yet. I just want to know like what stock and what dialysis company I'm going to be going to. Okay.
Yes.
Yeah. Okay. You're going to be at Hyde Park Dialysis. Okay. What I'm saying is dialysis from what? Kidney damage. And where is the most likely to get kidney damage in America? Come on, you guys all know it. The sugar, diabetes, right? Because once your sugar is over 180, it bleeds into your bloodstream. Your kidneys hate sugar, so it destroys it. Okay?
And hypertension.
Hypertension is the next one, right? Once your blood pressure is over 140, you get renal stenosis. Okay? So you have to make sure. Like me, I have Mediterranean descent. So you guys remember angiotensin converting enzyme, ACE inhibitors, whatnot? If you're Mediterranean, if you're a North African descent, if you're Middle Eastern descent, we have an adaptive protein that makes us have high blood pressure. And it doesn't make sense until I give you this conjecture. Is there a lot of fresh water in Sicily? Is it hot in Sicily? So what ends up happening is it saves me from being dehydrated and not perfusing my brain. It ups my blood pressure so I can perfuse my brain. Okay? So I can live. It's an adaptive mechanism. But like any adaptive mechanism, it can go too far. So every year, my blood pressure, I have to check to make sure I don't need an angiotensin converting medication to decrease, or an ACE inhibitor. My wife, on the other hand, her blood pressure is a cucumber. But what she can't do is she can't eat salt. So it's like the blandest chicken breast is brutal. It's brutal, man. It's like white rice and chicken breast. It's like, oh, it's horrible. Okay?
Rob,
So
what you got for dinner tonight?
white rice and chicken?
Rice and chicken breast?
Yeah, buddy. So, all right. So then we got temperature, trauma, tumor. Okay? Tumor, usually slow growing. The deficits get a little bit progressive, right, depending. Trauma, that tends to be rapid onset. We all know trauma, right? Temperature, too hot, too cold. Around here, too cold tends to be the good one, unless, number one, turns to a hot day and there's a marathon, right? They're gonna be outdoors, just bad. It's bad for everybody. Insulin, oh yeah. Too little or too much? Too little, your sugar's high, but you never got to the cell. Too much, you now start changing the osmolality in the cells. Okay? So we have to make sure, right? Because you can have so much insulin that all that sugar is being transported into your muscles and fat cells, and none of it's going here. Okay? Or you can have so much sugar that none of it's getting to the cells and it's floating around, but there's so much is changing the pressure in your circulatory system. Pregnancy, psychosis, and poison. You shouldn't put pregnancy next to psychosis. That's really kind of messed up. Okay? All right. Here's the deal with pregnancy. Being pregnant will not make you crazy. The sequelae from being pregnant might make you crazy. Here's why. We are now increasing your blood reserves. We're adding extra. We normally have, 5 liters? We might be adding an extra liter, okay? Number 2, you're now secreting different hormones. You have follicle-stimulating hormone, it decreases, and now your luteinizing hormone goes up, but your progesterone goes up, okay? And so, all hormones, I'm going to say this caveat, we all can deal with our normal hormone level, cortisol, anything, within our normal range. It's when we have swings that can really alter us. Anyone here ever been hangry? There you go. Anyone ever been sleep deprived and you're just like, mother, right? So pregnancy is not itself, but some of the swings in the hormones due to the child, right, might be in there, okay? All right. Psychosis. We don't talk about this enough, but schizophrenia is a big one. So I never turn my back to psych patients ever. Okay, I don't care. I'm always like, hey, what's going on? Okay, I'm always, because I don't know them, okay? And I want to be protected, okay? But schizophrenia usually happens for males anywhere from the 28 to 40 years of age, where they act normal, have no history of it, but there's a familial component. When you're on an emergency call of altered mental status, and the person is always acting normal, always find out their psychiatric history along with drug use. Because they can have a psychosis due to excessive drug use, right? Polypharmacy, they can have something else going on. They can have lead exposure, they can have a few toxins like that. So you just want to take care of yourself. Because, and I know this sounds horrible, you're going to treat thousands of people. I don't want someone to hurt you because that limits you versus you take an extra step and make sure you're safe, okay? Stroke, seizure, shock. All those are big. Altered mental status. They all change your medication. All right. Primary assessment, physical exam. Okay. The one I always like to do, I come in, all of you do the BSI scene say, How you doing? What's going on, sir? Right? Usually they'll have a family member who called, okay, just wait 1 second. Okay. Sick, not sick. Injured, not injured. That's how I'm gonna assess it right now. And then, okay, airway open and pain. He looks good. He looks stable. We're gonna deal with this one. My first thing is to be airway, breathing, circulation, mass bleeding. We're gonna make sure we go on that one. When I realize that you're safe, then I can get a history, right? Because your safety, don't mix and match the two, okay? So you want to make sure that the airway is oxygen, because what are we lacking? Oxygen to the cells. When we get an ischemic stroke, meaning a clot, their blood pressure is going to shoot up, okay? We're not decreasing blood pressure, ever, because that may be the only thing pushing those red blood cells to oxygenate, okay? Everybody repeat after me. Leave that to the people with higher malpractice. Okay? The person with the highest malpractice in the room, that's who you leave them to. Okay? You let them do that thing. You're getting them there. Your thing is time. I'm gonna get you all set. I'm gonna work you in the rig. I'm gonna get an IV on the fly. I'm gonna get hypoglycemia. I'm gonna get that all set. Okay? What kind of gauge do we need for an IV? 18 is preferable. They can work with 20 for a contrast. Okay? We need IV access. You've got to have it, because a lot of the times I'll go right to CT. I won't even get them off my stretcher. I'll literally give them a stroke test, and they know me enough. When I say they're having a stroke, they don't even question me. You guys are getting so good, they're not going to question me. Okay? They're like, hey man, blood pressure is this, glucose is this, right? Check both pupils. This is the reflexes, what they have. Boom. I got an 18. I got them oxygenated. This is what we're ready to go. So we want to make sure. And the big one is, are you going to hurt them by giving them Narcan? No. So while you're checking your blood sugar, if worse comes to worse, you hit them up with Narcan. As long as they're okay, right? I hit it up in the IV. I don't want anything that they could choke on if they're hypoxic. If that doesn't change anything, great. You just ruled out opiates, which means you ruled in everything else, which is good, which is on the fly. Okay? Okay. So altered mental status. Does that understand stroke? Does that kind of help? You're on a time crunch. Work in the ambulance, right? Once you ruled out trauma, right, and you don't have to support them, backboard them, make sure that they're safe, get them out and just go. Don't work on the way if they're stable, okay? Bring fire with you if you need to, okay? Make sure that you got extra manpower, but you want to make sure that you're going as fast as possible. Because every second that you save them is a second their brain cells are living, okay? So that's what you want. Alcoholism. All right, there's Wernicke syndrome and Korsakoff psychosis. Essentially, when you drink alcohol, it is a toxin, okay? And you're creating metabolites in your brain. They call it wet brain. You guys ever heard that term? And so you're creating, your brain gets swollen over time. It's called encephalopathy, right? Drinker's encephalopathy. And so what ends up happening is you're getting altered mental status because your brain essentially is swollen and bruised, and its metabolites are all messed up from alcohol, okay? And so alcohol itself isn't that bad, but excessive chronic use is too much. You get kidney damage, you get liver damage, you get albumin damage, and they can't maintain their pressure, and they can't maintain homeostasis balance, okay? Because our liver produces albumin, and when your liver gets damaged from drinking, you can't maintain that pressure. And so where does that show up? It shows into the brain. And so that's why you'll see a lot of chronic alcoholics, they're altered even if they're sober. Because the brain is so swollen and so silent, you can't make those connections. So, you want to hyperventilate, intracranial pressure, and mannitol. I don't think we use mannitol here, but I'll give you the reason why. Does anyone know what mannitol is?
Osmotic diuretic.
Yeah, okay. So, mannitol can't cross the blood-brain barrier, okay? So it stays in your arterial and venous system. And so, because it's osmotic, it's got all that, it's gonna draw pressure from the brain. It's gonna draw pressure from your CSF. And because it draws it, it decreases the pressure on the brain, it gives you time, okay? And because it gives you time, right, you're decreasing the pressure that your brain gets swollen. How are we doing on that one? Good? Well, hyperventilation. Okay. but we call it cardiopulmonary. So everybody hold your breath for me and feel your radial pulse. We go on 3. Okay, 1, 2, and 3. And we can breathe out. Okay. Some of us are in better shape than others. Okay. What happens is when you don't have pulmonary access, your cardiac is going to speed up to spin things around, right? It's cardiopulmonary. In reverse, if I hyperventilate with good oxygen, what does my heart work? Less. So my blood pressure comes down. And so that's why we hyperventilate in those
We don't
situations.
actually wanna hyperventilate.
What?
We wanna ventilate, but we don't wanna hyperventilate.
Well, yeah, we want to
Unless they're
ventilate
showing
with-
signs of herniation.
Yes, signs of herniation is a whole nother. We're gonna get there. So we want to ventilate good and oxygenate to get all of the red blood cells hyperperfused, and this will buy us time. What is our number one therapy? Is speed. Speed. Okay.
Can we talk about hyperventilation real quick?
Yeah.
So
So
what you were saying, because
we don't want to hyperventilate and increase pressure. We want to ventilate well.
yeah, with the textbook, they were talking about increasing intracranial pressure. The problem is we need to blow off the CO2.
Yes.
We want to constrict the blood vessels, but then that decreases
That
perfusion to the brain.
Brain, which causes more
So you have
intracranial
that
pressure,
balance.
that's
Yeah.
why,
And the balance is why you want to
CO2
titrate.
to 30 to 35, right?
Right.
So that's the measurement.
You titrate with the CO2, you're going to use your capnography. And you're going to use that as your, so I'll use a lot of oxygen and I'll use my capnography to balance.
So this is a capnography and titrate ventilation in order to match
Yes.
30
Yes.
That's it.
35.
But you'll notice people will hyperventilate because their cardiac isn't going well or their O2 isn't going well.
but the problem with that is then they're blowing off all the CO2
Yeah.
and causing
So it's
vasoconstriction,
tough,
which is
and that's
just
why-
circling them down the
But you're
drain.
gonna only hyperventilate them if they're sitting at 45 or 50.
Exactly, if they're up there.
Yeah.
Yeah.
Yeah,
But that's why speed is on your time, because they're gonna go in and do dialysis, and they're gonna run the labs, and they're gonna get there, and they're also gonna do scans of what they need to do depending on what you have. That's why time is really the best medicine you have, along with secure support and access. Because they're going down the drain. Your job is to get them before they fully go down the toilet, but your job is to make sure they have access to the least amount of time before they get all the testing that they need, so the intervention is appropriate for what they have. Because I don't have x-ray vision, so there's a lot of intricacies that you're gonna have, but you wanna make sure. They're all leaps of faith essentially until you get full testing, but you're gonna get the best scenario for them to succeed. Okay? Dispatch, grocery store. Person with slurred speech, upon arrival, 86-year-old male, sitting, display shelf. Is awake but confused. All right, so what do we got here? What do you guys think? What's your first thing you wanna do? You all know
That's what I
that.
was gonna say.
There you go, man. You gotta make sure no ninja is jumping out, okay? Every time I would forget it, somehow there's like a ninja fell off a roof and killed me, okay? So we wanna make sure. 86-year-old male. All right, so number 1, 86. First thing I look for, you guys instinctually look for, right? Trauma, no trauma, blood everywhere, right? You look. You might not consciously realize, but you look and, oh, there's blood everywhere. That's bad. Versus no blood, okay? So, are they sitting up? What does this tell me if they're sitting?
They're somewhat alert.
They're somewhat alert enough, right? And so what are you gonna do? You're gonna do your app. Sir, can you hear me? Are you alert oriented, verbal, painful stimulus, unresponsive? Okay? Do your app with your C silent. You know, scene silent. Okay? Pain airway, breathing normally, regular bounding pulse. What does this tell you? Okay? The airway is what? Pain. Great. So you don't need to take measures to secure the airway. Right? Breathing normal. What does this also tell me? Okay, so he's ventilating pretty good. Okay, he's not responding to the ventilations, right? Doesn't look like he had what, brain trauma to itself, right? Because you get a trained fewer what, medulla oblongata, so there's no alteration right there. Bounding pulse. Are old people hydrated or not? No. None of us are hydrated. Who here drinks caffeine all day long? Yeah. Okay. So patient sitting down, bounding pulse. Okay. Remember this, if you feel it on the carotid, that's roughly 70 millimeters. If you feel it on the radial, that's roughly 90. Check the carotid, then check the radial. You can feel it here, you'll be able to feel it. Just go down that way, okay? Pink, warm, moist skin, no bleeding noted, okay? Warm, great. Cap refill, good, right? Not hypothermic, so we just
that's
ruled out temperature. What do you want to assess? What do you think might be coming out?
Sugar?
Sugar, okay, so let's get some vitals. Let's get some sugar. How about a cardiac monitor? Make sure they don't have irregular beats.
Does he have a medical bracelet?
That's a good one. Check medical bracelet. Check bystanders. See if anybody's with you, knows it. There we go. This is working good. Okay? There you go. You're covering your bases. Okay? I'm gonna check pupils, all that. Right? See if they can follow H grades and look at each pupil. Right? It's kind of standard. Low. You want to think best bang for buck. Checking the glucose is great bang for buck. You get so much information for a small amount of test that you get definitive proof on it. Okay? All right. As positive for facial droop, slurred speech, right-sided R weakness. What are we thinking? Stroke, right? Because we ruled out what? Glucose, right? We ruled out history, right? I'm looking to make sure that there's no huge scars on the right arm because you might have just had surgery, so you can't use it, right? Not in the sling, so we're good. Blood pressure, 192 over 100, heart rate 98, rest 20, SpO2 98, blood glucose 144. Great. What do you want to do?
Load and go.
That's easy.
Okay, load and go. I like it. Access, no access.
Access.
On the way.
On the way, great. Monitor, no monitor.
Monitor.
Great, perfect. You want to make sure we get a monitor. I'd get a whole 12 lead on this one, get the 4 lead, then rule out with the 12 lead, right? Because he may be having a stroke. What's the #1 cardiac disease that gives stroke? AFib. AFib. AFib or recent history of surgery because they throw a clot post-surgery. You want to make sure that if they are post-surgery, you tell them post-surgery. If you've got a bystander who tell you post-surgery, post-surgery. If they have a history of AFib, we know we're going big, okay? All right. Do we want oxygen?
Yes.
Great. It can't hurt if we're trying to perfuse every blood cell. Do we lower the blood pressure? Nope. Keep it high. Keep it high. Okay. That's good. Questions? That makes sense on how I go about it? Okay? And so, let's just say a patient was having a stroke. I'll say, sir, can you hear me? Can you understand? I just need you to nod. Okay? Because nodding is different than expressing. Okay? I say, okay, do you understand me? And if he says something, then I know now he's what? He's not got the expressive aphasia. He doesn't even understand he's what? He has the other aphasia, right? You know what I mean? Because he can't, okay, he's caught up like this. I go, okay, look at bystander. When did this start? I need a time. I need a time. Because certain therapies develop on time. Your thrombolytics, 4 hours or less. After that, when they got to go in and do surgery. Okay? So we need a time. Say symptoms were apparent here. If they went to sleep, when were they last known well? Okay? Got to make sure you get the time in there because it changes the therapy. Okay? And I would sit there and honestly, if a person had a right side lesion, left side lesion, right side like this, I'm going to get them on the way. And when their blood pressure is that high, you know you're going to get an IV in quick. Right? Go to the hand, then go here. Okay? Kind of one of those where it's like, all right, I got one here, I'm relaxed enough, I can get one here. Okay? And so you got the leads, you go in there. All right, physical exam. Who knows pupils equal round and reactive? You guys know how to do this one? Where you shine a light in here and it contracts equal round and reactive. You want to make sure that they're not pinpoint and not too wide. You want to make sure when you shine a light in one, it reacts in the other one. You shine a light in here, it reacts in the same way. Your eyes are linked together. Okay? If your Edinger-Westphal nucleus isn't working, meaning something in your your occipital lobe isn't working, your eyes will not work together. Okay? That's one where you get like concussion or drugs or something like that. So you want to do people's equal-rounding active. How I would do it is like, sir, I need you to follow my hand for 1 second. Look right here. Awesome. Look right here. Up, down. We're gonna do one more time. Shine a light. Cool. Shine a light. All right. Thank you, sir. Boom. Done. Do this on the ambulance. Do it on the way. Everybody have a pen light? You got a phone. You got a phone. Just shine to the side. Just literally put your hand here. Shine to the side. You'll see the other eye closed. Okay. Lung sounds equal clear bilaterally because you don't want them to have a tension pneumo or hypoxic due to that. Okay. That's why we resuscitate 1, 2, 3, 4. Then in the ambulance, when they're stable, you can do a bigger scan. Abdominal, soft, supple, non-tender. What are we looking for the abdominal? Rigidity, pancreatitis, right? Triple A, burst, something. You guys done enough physical exams where you're like, oh, that's good. Oh, that's not good, right? Because we want to rule out infection. They got pancreatitis or peritonitis due to appendix inflamed. You go, they're going to jump up. Okay, so we want to make sure that isn't there. People don't always get one disease at a time. You can have a person that threw a stroke from AFib because they had an infection. That sucks. It's horrible. Okay? They're at the Pines. I had that happen. Patient was septic. They had AFib. They threw a stroke. I banged out 2 liters and got them up there. The reason that they threw a clot was they were so dehydrated with the AFib, they threw a clot because there wasn't enough to circulate around, so they were clotting in their heart. So, yeah, stroke, embolytic. Why embolytic? Embolytic just means a clot. So there's hemorrhagic and there's embolytic. Why embolytic? Why do you guys think this would be embolytic? Give an answer.
Signs of bleeding.
Okay.
No signs of bleeding like trauma.
So traumatic or hemorrhagic doesn't always mean trauma. Okay, you can burst a blood vessel inside your head. Okay, I like your thought though. That's external hemorrhagic. That's a good one. We're thinking sometimes there's internal hemorrhagic. Okay, and what you need to realize is that increased blood pressure is a big one, but this one, thunderclap headache, that's the big one. One of my coworkers' wife just had one. She's only 32. Okay? They have a congenital anomaly, they're getting fixed. Okay. He was right next to her, thank God. They were literally sitting there and she was like yelling at her kids. Another reason why having kids is tough. She blew right there. He looked at her and she went like this. This is how he explained it. He goes, I was talking to her and then she just went. And he goes, oh shit. Got the kids in the car and we booked it before the ambulance is there. Because he's out in the country. Okay? He got her there quickly. He works at Toro, right? And he got her there quickly, and they literally did surgery, right? They literally flew her to Westchester, did surgery, and she was fine. Because he knew the sign. He's like, oh, it took him 3 minutes to get to the hospital. There you go. Okay. So, normal artery for healthy non-EMS people. This is where you started the program. This is where you are right now. This is where you'll be when you graduate. This will be your first call because you're so stressed. Okay? Here you go. Okay. Anybody know Ted Marchione?
Mm-hmm.
How long does it take to clear as a medic? Like 2 weeks, right? Normally you ride for 2 weeks. Okay, depends. Ted cleared me in 1 day. He's like, yeah, you won't kill anybody, you'll be good. So I was like that show, Naked and Alone. And
Naked and Afraid.
I was like, I'm out here. He's like, yeah, you're good, you're fine. And all of a sudden they're like, yeah, you're fine. Go work Marvel 15 hours, no translator, no nothing. First call I do, right? They think she's having a stroke. Woman only speaks Italian. She was upset because her tomatoes were bad and hysterical.
That'll do it.
That was awesome. I get it. I love a good tomato sauce. That was my first call. It's like altered mental status, possible stroke, 90-year-old woman, irate, not speaking English, incomprehensible. Roll up. People are like, oh, she doesn't. I can't understand the Spanish because she's not speaking Spanish. She's speaking Italian. Did I turf her and AMA her? No, because it's my freaking first date. We're going for a stroke. Okay, so I want you to understand, these hemorrhagic are fast going. You don't have the 4 hours. Even on the thrombolytic and embolytic, you don't have 4 hours. You want it quick as possible. But for hemorrhagic, it's going to go south real quick. You could better be ready to intubate, and you better be ready to put an OPA in or NPA and be engineer with. If you think it's hemorrhagic, need somebody to roll with you. Grab a police officer, grab a fire, grab someone because you're going to need extra hands. Okay? Because this is what happens. You get the bleed on the inside and it starts spreading. Because it spreads, it increases your intracranial pressure, your ICP. And because it increases your ICP, there's only one way for your brain to go out. Down. And what's down there? Your respiratory center, your medulla oblongata. That's why you need somebody to help you. Once you get that, it starts herniating down. They start getting respiratory problems, cardiac problems. You gotta be ready to go. Okay? So I'm gonna oxygenate, right? You're gonna do RSI if you have to, right? If you get ahead of it, right? If you have enough manpower, RSI right away, you can if you're certified to. If not, be ready, you know? All right. And so, can you do this for me? This is your artery. It's nice, it's big, okay? When your brain gets pushed from the inside from another artery pushing the brain like this, do you see how this now starts occluding this? So your brain is in the skull. It's only got one area. So it starts occluding other arteries and veins. That increases the pressure. Then your brain literally goes out your foramen magnum. And that's your respiratory center. And then say let me. So that's why that intracranial pressure, thank you, good arterial structure. But that's why it's so important to make sure that you manage that ICP as best you can. Tilt them at a 30-degree angle if you can to decrease use gravity for your side. Okay? Make sure you hit it, lights and sirens. Make sure you get them well oxygenated, and you're gonna go. And you're gonna go, because every second it's increasing. Okay? So on that one, if the blood pressure's up, are we adding fluid?
No.
Just access. That's it. Okay? Ooh, stroke. All right. This is it. Facial drooping, headache, aphasia, dysphagia. There's a lot of the things. But the reality is this is what they're going to have. They're going to have all of them like this. Oh, like this. And they're just going to, and they're going to crunch down because that pressure is going to come up and their brain's going to actually start to hurt. Okay? And they're going to start going, and that's the start. You're going to see that. And then all of a sudden your language is going to change. And then it's going to get ugly quick. So, yes, you're going to have a headache. Yes, you might have facial drooping only if it's on the homunculus towards your middle cerebral. Okay? But if they have a headache, aphasia, right, and loss of consciousness and some hypertension, just because they don't have facial drooping doesn't mean they're not having a stroke. They're just having an artery have an embolism that's away from that facial center. It might be on the arm center where they're just like, my arm, it hurts, I can't. And that's, that artery went further down into the brain that only controls the arm. Okay? The blood pressure can be through the roof. They're going to be like this. They might not have any aphasia or anything like that. And so I had a patient, there's another battle with Dr. Moore, 62-year-old homeless man, right? African-American blood pressure, 138 over 72, wouldn't talk. Stroke, no stroke. Homeless, drug addict.
Don't know.
Don't know. So I sat there and I said, hey buddy, need you to close your eyes. He could close his eyes. Close your eyes. Open your hand. Feel that? Okay. write to me what was in your hand. And you couldn't write. Okay, follow me now. Just kinesis. He wouldn't talk, but he couldn't do it. He was having stroke only on the end part of the expressive aphasia to the muscles of the hypoglossal nerve. Dr. Morrow, onion bagel. Okay? So you don't need to have every sign. If you see that blood pressure slightly going up, and his blood pressure was going up by the minute, think you're hurt. Get tested. Okay? It's for the CT scan that they can do, Mid-Hudson and Vassar, they can throw away the money. They're doing fine for themselves. Okay? Be wrong, but be wrong on the side of the patient. Be wrong and an advocate for the patient. Okay? Don't be wrong not advocating for the patient. You don't want to be that side of the curve. Okay? Okay, so what do we got for having a stroke? What kind of test do you guys want to do? Easy test. What would you do?
Fast.
Hmm?
The fast exam.
Fast exam? Perfect. Explain to me. What are we doing? I'm the patient.
Hi, sir. What's going on today?
Chicken nugget.
Can you give me a big smile? Okay. Can you pick both your arms up for me? Your face is on one side, your arms on the other.
I have a facial palsy of the upper cranial nerve on the left-hand side.
Okay.
About that.
Can you say you can't teach a new dog old trick, or you can't teach an old dog new? I can't even. I'm
She's having a stroke.
Can't teach a bird chicken nuggets.
When did all this start?
Let's start.
When did all this start?
I don't know, he hasn't been right in the last 20 years that I've known him, but, I don't know, 20 minutes ago.
Chicken nuggets started 20 minutes ago. They're about ready to come out the oven. There's your fast exam. Face, arms,
go.
speech, time.
There you go. And that's it. That's how quick it takes. While you're doing that, right? BLS before ALS, right? I don't want to walk. I don't want to increase my muscle pressure on any of my pressure. I don't want to use any glucose. I don't want to use any oxygen. Bring the stretcher, put them on the stretcher. Don't have them walk to the stretcher. I don't want to shake loose any other clots that might be happening. I don't want them to use any oxygen with the amount of muscle that they have because they're struggling for oxygen. I see a cardiac patient, I see a patient with a stroke, they ain't walking nowhere, right? It's Cadillac service. Put on some oxygen, get IV access. Do not stress them out. No worries, sir, we're just gonna go get some tests. You're gonna be okay. I had patients hold my hand and like sit there, you'll be all right. I got you. Okay. This is the one time I tell people you're gonna have two voices. Okay. You're all gonna have your inside voice, and you're all gonna have your outside voice. Do not confuse the two. Okay, this is my outside voice. Sir, you're gonna be all right. Same as before. I got you. We're gonna take care of this. Getting the best help possible. Relax. You're doing okay. I got you. On the inside, this is what you're gonna see. Mother. That's the reality. I'm gonna tell you how it is. Okay? But you need, through your competence is just done by practice. You're going to calm them down to the best situation. You need to control the scene, or the scene's going to control you. They grab me, they're all like, you'll be all right, I got you. Here we go. Does this make sense? All right. Stroke, Cincinnati, that used to be the big one. Now they do the fast because it's just simpler to go by.
No, now they do the SLAMs.
Yeah.
Now
It
they
went.
slam.
It went fast. Cincinnati SLAMs.
Well, then, that got
We
fast.
are.
Yeah.
Yeah, we've
I
been
give
doing
a
this a long
full
time.
neuro, so I don't really go by that, but I get a little bit of leniency that way. You guys are gonna do whatever your curriculum says. Okay? That would be left up to Bernadette. Okay? All right. I mean, stroke scale, yeah, okay, cause we all carry this around. Okay? We don't. Have your stroke card on you, your SLAM's little index card on you if you need to, and then make a few photocopies of it and just be able to circle. Keep it in your paper. You know, everyone's got a notebook, hopefully. Keep your SLAM index on it. And just wham, 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 done. Okay. And then you hand it right to the doc right there and then. Take a picture, put it in your notes, you're good. Okay. It's really small. Okay. All right. It just lands like this. Right? You can do that. So, we're gonna pass like. Okay. What's the difference between a primary stroke center, right, and everything else? Because they're all primary stroke centers, essentially, right? Basic one is you want to know your level one. Your level one is really that's going to have your neurosurgeon on call all the time. So if you're thinking hemorrhagic, right, call, I think Vassar might have capabilities now, right, for it. I know Albany, I know Westchester does, right? You want to make sure that you go to the right appropriate place so they don't have to give med flight down, because that's time, okay? So there you go. Comprehensive stroke, that's the one. That's where they actually go in with a catheter and they can ablate and they can go in and literally pull out clots. Craziness, okay? Most of you are gonna work around this area or the other side of the river. Check out Garnett, make sure they have the right capabilities, okay? Because we want to double check. You want to double check on stroke, you want to double check on pediatrics and OBGYN, because they're always changing. Check.
Can't Manhattan do the thing where they pull the clocks out?
They might. I'm just saying, like, I'm not totally 100%.
I think they can, yeah.
Okay. I usually bring them to trauma. Let's be honest. I bring them to trauma. Anybody I want to die, I bring to that's. You didn't hear it. Okay. So, stroke, intracranial hemorrhage, that's different than TIAs. TIAs are transient ischemic attacks. These are basically vasospasms of your artery. You get a little one, they'll maybe throw a tiny clot. Here's the trick with TIAs. They mimic a stroke, but your symptoms go away. So they might go away within an hour, they might go away with 50 minutes, they might go away in 2 hours, and they might not be as severe. Here's the most important thing to know though. TA is usually before somebody throws a clot and over the age of 20, okay? So if someone is having stroke-like symptoms, I don't care if it resolves. I'm bringing them in for 3 reasons. Number one, they could be throwing a clot right afterwards. Number two, let's get a baseline look at the arterial and brain structure to make sure there's no further damage. And number three, they're going to get them on medication so they don't have a problem in the future. So you want to make sure, even if it's a TIA, right? You want to make sure that you get them for testing, okay? I'm not going to let them say, oh, I'm going to AMA. Like, dude, you just had a freaking stroke, right? So I'm not going to tell them they had a TIA, right? Transient ischemia. They're going to go on Google, okay? And they're like, I'm going to AMA. And then when they have a stroke at nighttime, who's on the line? EMS showed up, let me go with a TIA. And then you're going to go to court and be like, they signed AMA and they looked up on Google. Like, how is that going to look? So you're going to say, because you can't rule out a TIA because you don't have x-ray vision. For all intents and purposes, it's a stroke. Even if all the symptoms resolve, you don't have x-ray vision. You'll get destroyed in court doing what you consider the right thing, but it's the wrong thing. Okay? Give it to somebody who has higher malpractice. Okay? You guys are working hard for this license. I don't want somebody looking up Google to ruin you guys. And more importantly, it's never going to end up good. No one's going to end up happy, no matter what happens. Okay? Some of the symptoms, right? High blood pressure, prior stroke, TIA. Here's another one in this world. Change in medication. Anytime you start adding hormones, birth control, chance of increase of clot. Adding testosterone. A lot of guys listen to Joe Rogan now, okay? All these 40-year-olds just taking tons of TRT with no blood work, okay? On a carnivore-only diet, all right? Like, like they get crazy, okay? So like, you want to say any Trojan hormones, anything like that. There you go. All right. Got that. Facial droop, pronator drift, right? Okay. Tends to a stroke. Blah, 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 blah. Okay. Don't use that 18 years and older. even though it says it, don't. Okay? And I'm gonna say this nicely. Who here has aged a lot since they've been in EMS? Yeah, he was 20 last year, okay? So, I don't use age as a distinguishing characteristic when I do stroke. Okay? Don't quote me on this, but I'm gonna say this right now. There's a lot of 17, 18-year-olds vaping away, right? Living a hard life, okay? They might have come from another country and subject to a lot of toxins and trauma. They may be over here and they're near like a factory that they have a lot of trauma and built up accumulation, okay? So I don't do the 18. I can't sit there and go, well, you're 17, 11 months in 4 days, so you're fine. Okay? That's why I don't even bother with that one, to be honest. Now they're gonna say, you gotta know this. But in the reality is don't exclude because of age. Okay? Alright. Local soup kitchen, man down, never would happen. Second floor, no elevator, never an elevator. Never. Are the stairs gonna be straight, easy to get up? No, they're gonna be the curvy ones with vomit on it and homeless people sleeping. Okay? What equipment do you need?
Firefighters.
All of
I'm
the equipment, and firefighters, all of the equipment. You know why? The one day you don't bring suction, what do you need?
Section.
The day you don't have a glucose monitor, you
Glucometry.
need it. Right? Like, it's always that way that one time you forget something, that's the time. Oh, you don't have your leg immobilizer for the femur fracture that you learned about in class? That's the time you're gonna have an accident where you have a mid-shaft fracture. Every single time. Okay? Oh, your friend says, my bag is good, you can take my bag, all the meds are in it. The battery is good on my laryngoscope. No, they're not. No, they're not. Okay? It just always happens that way. Okay. Patient's, of course, 6'6", 280-pound male, convulsing on the floor, large jerky motions. All right, what do you guys call this? What do you guys think? Jerky motions, 6'6", 280 pounds. What do you guys want to call it? Seizures. If you're really smart, say this is a pain in the ass. He's 6'6", 280 pounds on the second floor. Okay? You got a 280-pound guy having seizures. What next? What do you guys want to do? You are the adult in the room.
Are you an 911?
What do you guys want to do?
Can we lower him out the window like a piano?
That's perfect. Make sure there's no ninjas. Great. Next one. ABCs. Just go down your algorithm, right? APU, ABCs. Just because he's decided to convulsing, make sure he isn't snoring on his tongue and he can breathe. Make sure his respirations are within normal limits and they're able to ventilate. He's got chest rise. Is he circulating? Does he have a carotid pulse? You got to perform CPR right there and then. You just did your APU, you did your ABCs, and you indicated you don't need CPR. Great. Does that mean he's good? No, that just means he is not dead yet. Great. Okay. Rapid, noisy respirations, irregular pulse, diaphoretic. No response. So there's your APU, right? No response to pain. So he's unresponsive. Okay? Urinary incontinence. Well, that's not good. Okay? You thought it was DTs? Ray can be okay. All right. So what is this called? Yeah. All right. Epilepsy, staticus, or depending on Latin static epilepsy. This means a sustained epileptic damage, and he's just going. Okay. So what do we need to do? Airway. Okay. More likely than not, if he has no corneal reflex, I'm going to put an OPA so he doesn't bite down in his tongue or swallow it. Okay. I don't need any problems that way. Okay. But I'm also going to put an MPA in because if he starts coming around, I just pull that and he's good to go. All right. Are we going to breathe from him? What do you guys think?
Yeah.
Got noisy respirations. Rapid. Put him on your OT, bag him if you need to. he might have rapid because his tongue's in the way. He's just, okay? That might clear itself up. Okay, so I'm gonna get his vitals. I'm gonna check blood sugar. Okay? Pupils are dilated, slow to react, heart rate regular and bounding, blood pressure 174 for 120. No injuries, no track marks, okay? Great, no deformity. Post-traumatic epilepsy and prescribed Dilantin. What do you need to do for this patient? Now, what's Dilantin? What kind of medications are for? Seizures, okay? What do you carry that's good for seizures? Person. How do you guys like to give it? IV?
Are they
IV?
actively seizing? Are they they're still
They're
seizing?
actively seizing, right? So do you want to do
I'm
IV?
giving
or you
IM.
want- IM. Okay. That's a good way to go. I give it intranasally. I don't like to have a free floating needle while a guy's jerking on me. You can give it intranasally.
Cool.
Okay? And keep it on my side. Right? Now what else do you have to worry about? What does seizure mean? What does it mean to you? Seizing. Alright, what? Muscle contraction. Contracting. What does that use? Glucose and oxygen. So you want to get some O2 even if it's low by, right? Or bagged. And we want to look at glucose to make sure he isn't going hypoglycemic. The next one is sometimes metabolites, they have to blow off the CO2 because they're using all of it. Okay? What you want to make sure that you get all set. Okay? Assisted ventilation, good idea. There we go. Start an IV and administer while he's shaking or after he's done shaking. After he's done shaking. If not, you gotta hold him down and you gotta get there. That's a real pain in the butt. Okay? It happened to me at Bosie's. A larger gentleman had a seizure in the bathroom. So I got an IV up in here because he wasn't shaking his shoulder, shaking his hands and legs. I literally went for the basilic vein up in the shoulder. I went right to the delta pectoral groove and just hit it there. So literally had an IV sticking out from here. Okay. Yep. Versus Ativan. I don't like Valium, to be honest. I don't know if we carry it. We used to go PR, right? In pill form, right? Ativan, sometimes it can actually make the seizure get a little bit aggravated into itself. It's one of the known side effects of it. You have to titrate up. Versed tends to work good, okay? And then you monitor the patient. And then what are we gonna do? We're gonna let them leave or are we gonna go where? To the hospital. We wanna make sure that they didn't cause any damage. Do we hold down the patient?
No.
No. They can fracture their arms, they can fracture their legs. We're gonna put padding behind their head. You don't smash your head into the ground. Don't hold down from the shoulders, okay? Because I've seen that where people have seized so hard you hold down, they actually break their humerus. Bad. It was a little old lady, okay? Didn't go well. So you secure and you can put them on your stretcher, put up the wrappings on it, and then all of a sudden you're gonna seize in the stretcher, but you're gonna have a secure area, okay? Defined by temporary alteration of behavior due to massive electrical discharge. Usually the corpus callosum is faulty, so the discharge happens on the right and goes to the left. That's why they have global seizures, okay? Stresses the body, hypoxia, big one. Change in blood sugar, always that one. High fever is a big one. High fever alters our cell membrane to electrolytes, so it makes you fire when you shouldn't fire, okay? Another one is changing seizure meds. You're coming off, or you're having what? Detox tremors. You can get seizure-like activity because your brain is now has altered electrolyte imbalances. Okay. Most common is pediatric population is fever. Okay, and that's the worst. Febrile seizures in a kid is just like absolutely horrific, and the baby's gonna be super, super hot, but they're gonna look blue because they're being hypoxic because they're not breathing well because they're using up all their oxygen, right? And so they're basically gonna hand you a floppy hot baby. So your big one is, if you feel that they're hot, right? You're gonna put ice in your groin area, use your ice packs, you can do that one. You're gonna ventilate, make sure they have oxygen, and you're just gonna control your ABCs, and you're gonna go quickly. Because you might have to deal with the mom, she has a panic attack, and then she goes unconscious because she's hyperventilating. So now you got two patients in the back of an ambulance, in a tin can, in the middle of the night. Yeah. And you can't call backup while they're in your ambulance without getting laughed at. Okay, just gonna play that out. But anytime you need help, call. Just be ready that they're gonna make fun of you for like at least a month or two. Okay. All right, tonic-clonic. These are called grand mal seizures. People can feel them coming on. Anyone here know someone with seizures? All right, we'll find out. Get like a friend. Okay, go online, but they'll sit there and go, oh man, I think I'm gonna have one. And usually they'll take a medication, PRN, they'll have their baseline medication, but they might take something extra right there and then, they up their dimension or something like that, or Keppra or whatnot, to make sure. But they'll know it's coming. Like, I was having a ward, I just felt it coming on. And they get like freakishly calm about it. Like freakishly calm. What's your first name again? Brendan. Like, we'll be hanging out, like, hey, Brendan, I don't really, I think it's coming on, don't worry about it, man. Cool, how was the game? How we doing? Yeah, well, they'll just do it, I mean, for minutes, they'll just seize in front of you, right? And then come back and you're like, oh man, it's cool. Did the appetizer get here? Like, what happened to the wings? Like, they will, because they're so used to it. Meanwhile, you'll sit there and go, what the heck? What just happened, right? But you gotta have that calm face. Yeah, no, I've seen that before. You're okay. Grandma seizures. Yeah, taking Keppra. Okay, no worries. We're good. We're just gonna go to the hospital, right? For me and you. Like, you're gonna be like that. And so you have to understand that people are gonna feel it coming on. Now, there are seizure disorders where people don't seize. Meaning they don't have the grand mal seizures, but they'll like sit there and just like zone off. Hey man, what's going on? I haven't seen you in a long time. And they'll have absent-like seizures. They usually will be diagnosed by a good pediatrician when they're young, but you'll see this, and then you want to get a good family history. What's your number one job when an absent seizure?
Make sure that they don't fall.
That's it. Absent seizures are real dangerous. Seizures while driving are real dangerous. Okay? A lot of people that have seizures, you're going to get to, and they may have never had a seizure before they have an infection. You can't let them drive. They have to get cleared by a neurologist. Okay? Do I want you on the Tappan Zee driving a Mack truck? So yeah, you're fine. You don't have seizures. But if you had seizures, that would be like, excellent. We're not having that. So a lot of people, when they have seizures, believe it or not, you guys need to make sure that the doc understands how long the seizure was. Did they have fasciculations of that? And you got to make sure, because now you're posing them to a risk to everybody. And you don't want, they don't want to hurt anybody. And you don't want, and it could be something as simple as just changing the medication. We'll have you drive in 2 weeks and you're good to go. That make sense? Questions?
I have a question. How do you tell the difference between a TIA and an absent seizure, because they both kind of present a little bit similar?
The CT scan will tell.
Yeah, but I'm in the field, I don't have the CT scan to
That's why we
determine.
go hospital. That's why we go hospital. If they call you, what does that mean? They need help, right? Nobody calls for no reason. Well, all right, never.
Like, wait a
Hey,
minute.
all right. Generally, though, if you get a call for that absent seizure, they know they have a condition, because it usually starts early and they have a history of it. And they're like, no, I have a history of seizures. Here's my wallet. This is my this is it. okay? And they're gonna have a history, and they're gonna see the neurologist, and then you can let them sign AMA because it's under control as long as they have someone with them. If they have no one with them, you're gonna advise against it because you have no one with them. And now this is a breach of duty. If you have a TIA, they're gonna wanna go with you. I've never had somebody with a TIA when you explain it, like, hey, you had a TIA, you know, I know this is transient and you're getting some of your feeling back. Let's get this tested because I don't want a big one happening without medical care there. Okay? Let's get a baseline, let's get a CT scan, let's make sure that you didn't do any damage. And then all of a sudden everyone, you know, a lot of it is what crisis and patient management, it's just communication skills. And informing your patient what it could be and what it might not be is gonna be on you to kind of, hey, you know, I know that you felt some disturbance in your face and weakness down your arm. These are all signs of a stroke. Even though you feel better right now, I've checked your sugar and it's good. I checked your heart rate, it was good. I checked your EKG. So the only thing that's really left, besides endocrine and something going on in your brain, is that's it. So let's go to the hospital and get that checked because I want to make sure everything goes safe for you. You're a young guy, and you have many years to live. This could be nothing, but I don't have X-ray vision, and something happened. You see how you're just going to control the scene like that, okay? And your job is to get enough information so they diagnostically get them to CT versus they get them to the lab. You want to make sure that you get them all set that way. All right. Postictal, confused, fatigue, neurodeficits, incontinent. This means they have so much seizures that just everything shut off. One of the most common side effects is urination. Okay? So you want to make sure you know that. They come back and they're like, I wouldn't say normal, but they just come back and go, man, what happened? They almost look like they're recovering from like being drunk. Like, I just feel off. Like, like you had a seizure or something. Okay? Don't worry, we're gonna get to this. We're gonna find out what it is. And a lot of people are like, oh man, I don't sit there, I don't want this to be. I go, no, it could be something simple as electrolyte misbalance. The weather's changed. But make sure it's not a chemical that you might have accidentally inhaled at work. Let's just double check. A lot of our job is what? Communication. Is convincing them to get to the hospital before something really bad happens. And you securing them on the way. That's what your skills are going to be. Yes, you can handle the crisis. The crisis almost is sometimes easier. It's these soft skills you're going to manage. And you're going to manage them because you're knowledgeable. All right, seizures, history, head trauma, alcohol, drug abuse, right? So basically, everything the same scene as what? Stroke. Your differentiation is going to be what? You don't have X-ray vision. So you're just going to treat it almost the same way. Okay? You're going to get access, you're going to maintain airway, you're going to get breathing, you can get glucose, you can get your EKG, and you're going to secure the patient. And you're going to find when last, no one well. Okay? The resident's going to take a look and you're like, hey, the patient had seizures, this is what I found, right? Noted this, started here, this is when it ended, okay? They're talking now. And then when you bring them in, the resident's like, no, we're having emergency CT, right? Or your resident may be like, okay, let me check them to make sure they're not, okay, put them into trauma 1 and we'll dictate from there after we get labs and a quick ultrasound scan. Like they can do certain things, your securing them is going to dictate where they go. Okay? Questions? We got break time or we keep going? What do you think?
You guys need another 5-minute break, or are we good?
It's up to you guys. You guys vote. Hands up, hands down. You guys need a break? Raise your hand. It's okay. I get it. It's neuro. It's fine.
Take 5 minutes. Go walk around, stretch your legs.
Walk around. Have another.